Hi everyone, my name is E. David Crawford. I'm from the University of California in San Diego. We're going to embark on a webinar, and this is sponsored by Verity, makers of Star, and it's on androgen deprivation therapy. It's in a series. This one is entitled Androgen Deprivation Therapy is the Building Block for Advanced Prostate Cancer. There have been a lot of things that have happened in the last year or so that have affected androgen deprivation therapy. We're going to cover some of those today. The outline is here on the slide. There's a lot to cover about this being the foundation and about options and how do you define castrate levels. There will be a lot of discussion about that, late effects, variations, side effects, implications, and also future directions, which is very exciting here with androgen deprivation therapy. So just drilling down a little bit deeper, we're going to be talking about the current role of foundational therapy and then move down to some of the stuff with the new adjuvant therapy and trials that are out right now and moving the treatment earlier. Joining me for this discussion, two veterans in the area. First is Dr. Scott Selinger from Tallahassee, Florida. Scott really has dedicated his career to prostate cancer and is a well-known leader. He's in LUGPA and actually president-elect of LUGPA. We have also joining us Dr. David Morris, and David is a Nashville guy, trained there, went away, came back, and runs a large group there. He, again, is another leader in the area of androgen deprivation therapy and advanced prostate cancer and advanced prostate cancer clinic. Guys, welcome. Thanks for being with us tonight. And I know you two very well. You're not going to hold back any bars, so it'll be an interesting discussion. So thanks. I'll start out with a little bit of getting things moving. We have a lot of options for hormone therapy. A couple of us just grew up with estrogens and castration, bilateral orchiectomy. Along came agonists, GnRH antagonists. We've got anti-androgens. We're now probably in our third generation of them. Exciting options exist with them. Combined androgen blockade, 1720 lyase inhibitors, and it goes on and on and on. We'll talk about this in a minute. We call it androgen deprivation therapy, but I think the name needs to change a little bit. I like the term androgen-directed therapies, which cover adding on things and cover some of the other things, anti-androgens and so forth. Just in the way of history, I like history. Interestingly, the first effective oral treatment for any cancer was estrogens for prostate cancer. 1941, Huggins and Hodges. Also bilateral orchiectomy, won a Nobel Prize for that. In 1966, that's when Huggins won that Nobel Prize. In 1971, a very good friend of mine, Andrew Shalley from Tulane at that time, isolated the structure for GnRH. He wanted to develop a compound that could be used in a lot of things and was helpful in prostate cancer. The first one he synthesized in 1973 was triptorelin, which we'll talk about in a minute. And then we'll talk about his Nobel Prize and things that happened then. We have to think about it. There's a number of GnRH agonists out there and antagonists, but here's the structure. The GnRH is a decapeptide, and it started out with manipulations of the sixth amino acid, and then you see that some of the other ones have a couple other things, leucine, and this is leuprolide and so forth. So the mechanism of action of triptorelin is a little bit different. It's only a single amino acid, and we just want to tout some of its values here. It has a long half-life and a very high biological potential, 131 times more potent than our naturally occurring GnRH substance. All right, now let's get into the discussions, and that is how do we define castrate levels of testosterone? Here's a slide that's out there that has a bunch of studies. So let's get into this and say, Scott, you probably grew up a little bit with the less than 50. Are you still thinking that now, or we'll have a couple of slides to talk about that, but what are your thoughts?
I did grow up with less than 50, and I also grew up with bilateral orchiectomy, which is what we're looking at here. That's what we did because that's all we had in the 1980s when I was growing up in urology. And so I did a lot of orchiectomies, and our goal was to get that testosterone less than 50 because that's what we could measure. That's what we could measure. And so now we know that actually with orchiectomy, we do better than that. With better assays now, we can see with these studies here that testosterones of less than 20 and even less than 15 are really more of a target for true orchiectomy levels, post orchiectomy levels.
So that's the bar I think that we should accept, and there's been some, as there hasn't been widespread acceptance. David, what are your thoughts?
I mean, certainly the FDA has their definition of less than 50, largely as the history of this. I think many of us have seen frustrations with labs, either we run internally or reference labs that we utilize outside our offices, that you can send the same patient's lab level off for testosterone and get vastly different numbers. And hopefully they're all under 50, but having just seen an orchiectomy patient today whose testosterone level was 32 by a lab, there's still some variation, and unless you really dig into what your lab company is doing, you may not have an idea if you're really trying to see that less than 20. But I think we all agree that the lowest you can get it is the best. It really just comes down to how you're going to measure it.
How low can you go? Well, you're right. There's been a lot of discussions. Groups got together. We got together back in 2012, called ourselves the Bethesda Consensus, and we said less than 20. But you're right. The FDA has sort of balked at changing that, and that's because a lot of the studies that were done early on that you couldn't measure them less than 20. The guidelines are variable, and a lot of us feel that. So I just want to run and this is a group that got together this about a year ago in San Francisco, U.S. Prostate Cancer Conference, that discussed a lot of things. It was composed of med-oncs, 53%, urology, 29%, rad-oncs, 16%, nuclear medicine. You can see the breakdown in some of the attendees. Not all of them are listed here and on the call tonight. And so we ask a lot of questions, and it was sort of a Delphi type thing. But one of the questions we asked, number one, was in clinical practice, what should be the target testosterone levels for patients receiving LH charge agonist antagonist for ADT? David, how would you answer that?
I mean, I imagine the experts would say less than 20. I think, honestly, the answer is if you're using something to stop testosterone, your target should be 0. We can't get there just on the hormonal axis we're talking about. So the lower the better, but I think most of us say clinically the data supports less than 20 as a great target. Now, do you accept less than 50 is a different story.
So, I was a little surprised about the answer we got back from a group of experts, and that was just 68% of them felt that it should be less than 20. Scott, you were there. What are your thoughts about that?
I was equally surprised. I answered it less than 20, and I was surprised the number of people that thought that 50 was adequate. But maybe it's like Dr. Morris said, they may just be going back to the FDA definition and how all the clinical trials used less than 50 for approval of the drugs, and they settled for that. But I think that for those of us that do it every day, yes, less than 20 is really ideal.
Right, and we see much lower than that. I think that we're going to come back to this because I think it becomes important when we define castrate-resistant prostate cancer and what T levels should be. We really owe a lot of this research to some of the people listed on this slide, Verity and Perkino and Lori Klotz, but so you say, okay, what testosterone levels, what does it matter? Well, it matters if something that happens, like the PSA goes up, or else you develop castrate resistance earlier. And Juan Maroti was really the first to bring this to our attention with a small study of 73 men showing, as you can see, they call it androgen independent prostate cancer. If you were less than 32, you got 137 months before that happened. If you were greater than 32, it was 88. And if you look across the board here, there's a lot of studies, and the one that is the largest one was the study that was an intergroup study that was done for biochemical failure for radiation patients. And again, Dr. Klotz and his associates showed that the lower, the better, and the difference in time to development of castrate resistance was significantly different. Let's ask another question, and David, I'll ask you to answer this first. In your opinion, how important is it that LHRH agonists be administered on time? Exactly, depending on if it's a 1 month, if it's a 3 month, 4 months, if it whatever. So is it important to deliver it exactly on schedule, or within a couple weeks is acceptable, 3 calendar months are acceptable? Let's see what are your thoughts on that, and I'll show the question.
Well, I mean, I think from my perspective, in the real world setting, within a few weeks is reasonable. As any of us who run a clinical practice know, 1 day too early is definitely too early from a claim standpoint. And even though these are done by days, most of us do this by months. And so with weekends and holidays and things like that, we all know there's a tail on these medications. The tail does not last forever, but I think the tail does give us coverage to maintain suppression for a few weeks of interval dosing.
Okay. But you wouldn't say that about a 1 month depot, no.
No, I think the shorter the depot, the shorter your tail. But certainly, I think for people that are using longer depots, I think you probably have more leeway in terms of your dosing timeline.
So I think you mentioned something else very important, is that we use a month, but that's 31 days. But in the studies, the month was 28 days. So we asked that question. And the group thought sort of the same thing with you. We're looking at here 84 days. We're looking at a 3-month depot with a 28-day month. And they thought that a couple of weeks was acceptable. Scott?
This is interesting because you've got government regulations and payer issues mixed in with what you really should do. And we know that based on the studies that the drugs were approved with 28 days as a month, but there is no months that have 28 days on a regular basis for that matter. And the problem is that if you give a drug too early, you get slammed, and you won't get paid for it, and so people won't take that risk. So we're really forced to be late delivery methods. That's just what we have to do, only because we can't give a drug earlier than that.
We actually looked at that, and this is a manuscript that we published a couple of years ago in the Journal of Urology. And so we looked at late administration and on-time administration and what it meant. And we were very fortunate to have a great group of people involved with this. And what we basically found is that if you look at the 28-day month, when you did administer it late, you started to have breakdowns of testosterone and suppression. And if you gave it an extended month, so you gave it a couple more days on it, what you see is that nearly 1/4 of people, and so these are men that are on the 1 month depots, had a breakthrough and had testosterones above 50. So, an extended month was giving a couple more days. That was sort of an eye-awakening experience, and that also that we're looking at greater than 50. If you look at greater than 20, almost half of the people did that. What do we do about this, Scott? I mean, we also showed that 83% of the time with all these depots, they were not given according to the guidelines that are cover the package insert.
Yeah, it's really scary, actually, since we know that these breakthroughs of testosterone, these surges, are detrimental can shorten time to castrate resistance, shorten overall survival. Yet this is common practice. This is exactly what we do. And I think that if you ask people that haven't read that manuscript, I think they would be shocked actually that even a day or two or three can make that much difference. I think that people have just kind of gotten a little lackadaisical and they say, yeah, couple of weeks, okay. Try to get in as quickly as you can when you're late, but it really does impact that. And so this is pretty significant.
David?
Well, I think the key is this question here, which is not necessarily about what your tail is or what your dosing interval is, but what is your testosterone? Because that's really what you're getting at. That the concern is the delayed dosing is leading to higher T levels. And if you never check a testosterone when you're actually having somebody on ADT therapy, then you're kind of lost in the woods. So I think we've all seen our own patients that have gone past intervals and missed doses. And if you check their testosterone, some of them are still fine, but yet we still have some patients whose testosterone starts to escape. And the reality is, if you don't look, you're going to think you're doing the right thing, when in reality, you need to be on top of testosterone more than you care about calendar days, I think, more than anything.
Yeah, the thing of it is, in that last slide here, is that you could see if you're a few days late, and if you just told me, a lawyer would have a good time with you in court there, David. You said less than 20 is where you should be, and Dr. Morris, you're going to give a treatment at 43% of the time if you're a couple days, and you said a couple weeks late that somebody is going to have a testosterone above 20.
Well, I guess the good news for my defense in court is at least I could say I checked the testosterone, which is probably more than most of what is happening in America.
Very good. That's exactly exactly what you need to say. So now that the next question is, do you monitor testosterone regularly in your patients? So Scott, I'm sure you're going to say yes.
Always, always. Yeah, I have it pretty much a standing order. Whenever I order a PSA, I order a testosterone with it.
Yeah. David?
Yes, I agree. That's operational question. For some people, they come in before their visit so that they know what their labs are when they show up for the day of their visit. And if we do that, we're checking PSAs and testosterones. But if I draw it the same day we're dosing, we will check both just to confirm.
Interestingly, our study showed that what was more commonly drawn was PSA and not testosterone. Everybody said that they do monitor it. The question is how often you do it and so forth. All right, question 4. When initiating ADT, when should T levels be measured? So I just asked that. Scott, where do you fit on here with the answers?
I try to measure it every 3 months, and if I'm giving a long-acting ADT, then I'll catch a PSA and T level in between their injections as well. Some of the time, though, if you have people that are coming from far away, or it's just not practical for them to travel that much, then I may extend it a little bit. But I want to know what that number is pretty regularly. And it was hinted earlier that these T levels can also be extremely variable. If there's any lab that has what you would call lab error is testosterone. I will get some absolutely crazy numbers sometimes where I know that they're on time, and I'll get a number. I just had this the other day. Someone who's been on ADT for years who had a T level of like 250. And I said, there's no way that could be. And so I repeated it and it was 10. So I think that's another message here is that if you get a number that's totally doesn't make sense, you really need to check it immediately, recheck it, and then you need to go through your algorithm of if it is real, then what's the cause of that?
I think we have to remember in most of the studies that have been done with these agents, what they need to do is suppress about 94% of the time. Again, I'm sort of shocked at this, is that there's a lot of variation. Only half of the people do every 3 months. And a lot of them some of them will curtail it when it's less than 20. Let's move on to a more sort of controversial thing. Could failure to monitor testosterone lead to an erroneous diagnosis of castrate-resistant prostate cancer? Yes, no, not sure, abstain. What do you say, David?
I mean, I've seen this on referral from some of my partners. A patient comes in who's been, quote, on ADT and now has a rising PSA, and the first thing we do is confirm if they're actually castrated or not, and lo and behold, they're not. So the assumption was their CRPC because their PSA has gone up, but in reality, they've just had an escape of testosterone or for some reason missed a dose of ADT, and we're just assuming they've progressed.
Yeah, and there's other reasons too. You can have user error. We've had situations where we've had nurses that may not have been adequately trained, that weren't giving the injection correctly. You can do the root cause analysis and go back, and if you've got a series of patients, you can find out where it happened from. And then, and there's drug storage issues sometimes with a bad lot of drug. So there's reasons that they can be getting the drug, so-called getting the drug, but actually not being effectively administered either. So you absolutely have to know. I can't imagine. I don't know why anybody would say anything but yes to the answer to this question.
Yeah, well, I think it's a serious problem though. And that what do you do? That all the LHRH agonists are not the same. They have different tails on them, and I think you've got to look at the data on them and what's the best things to use in patients, and maybe even switch. I mean, I've switched from one to another when I've seen this. But if somebody has a T of 40, are they really castrate resistant or not? I don't know, but I think that you want to get it down way less than 20 and down as low as you can go, as you said, David. To start out with is something to consider. And I guess that the next thing is are randomized trials necessary to elevate differences in efficacy and safety between agonist and antagonist? And we're not really taking a big deep dive into this right now, but there are agonists and there are antagonists, and there are differences. And we know that Shally, when he started out, he wanted to get an antagonist, but for a number of reasons ended up with triptorelin, and it's worked very fine over the years. But are there differences that we need to do trials? Yes, no, any differences are small or abstain. What do you think is going to be the answer here, David?
I mean, I think if you want to make claims that there are differences, then you would need to run randomized trials. I think they both do a good job of suppressing T, as you mentioned, in greater than 94% of people. But if you're going to make comparative claims, then you would need some sort of randomized data to back that up. It's very challenging to compare. All the trials make all of the drugs and all of the compounds look very effective in most people. So that's kind of where I stand clinically, because we use both of them.
The audience was, as you said, only less than half said you needed to do it. But your point, I think, is spot on. If you're going to make those sort of comparisons, you need give me the data. Scott, you agree?
Totally. And what we were looking at mostly is a real world evidence type data that we have, and you can make tables and tables and tables of those. And for every one that you see that shows an agonist has an advantage over an antagonist, I can show you one that's just the opposite. And that's what we have right now. That's what we have.
Get into that. So the ADT and the perception is that agonists are the same based on outcome, all the agonists. And I don't think that's true. I think you've got to look at them, the tail coverage, the suppression and things like that. Scott, you agree?
Sure. I mean, they're different molecules. They have different delivery methods. They have different time intervals, and all of that plays a role. And I think that if you are achieving what you want to achieve, and I think that's the other thing that's the no-brainer here, is that when people are challenged and they say, well, why do I need to measure these testosterone levels? What is our intent with ADT? The intent is to lower T, and they focus on PSA, which is the wrong thing to focus on, really. If you really want to know if your ADT is doing what it's supposed to do, you need to know what their T is. So if you're missing it, if you're missing out on T suppression, then then switching to a different molecule is certainly reasonable. And that just speaks to the fact that they are different and they have different effectiveness.
Well, that's perfect because you addressed the last statement here, is recommendation to change switch. If T is above your level, whatever you define as castrate. And the answer, I think, is yes. And this is why I got two brilliant people with me here right now. They've already answered the second question. David did. Is this simply an absence of evidence and no comparative studies, and need to do that? And you, Scott, covered this. Agonists are different molecules. We showed that in one of the first slides, and there are different binding affinities and outcomes. And I think you need to look at that when you choose your therapy. So let's move on here. We finish up the last 5 to 10 minutes on something that's exciting. And then we've also said over the years that every cancer that does well, it's not treatment A followed by treatment B followed by treatment C. It's combinations. That's how you cure lymphomas, leukemias, things like that. It's not ADT alone. And so doublet therapy and triplet therapy, we're in that right now. You know, it's taken a long time to get here. So now we have combinations occurring in metastatic castrate sensitive, non-metastatic castrate resistant, and ARIs. What are your thoughts about that? And then David, I'm going to ask you to just talk a little bit about the EMBARK data and what your thoughts are about that. So Scott, what is your optimism with doublets and triplets and different mechanisms of action?
That's very exciting. Like you said, we're catching up to other cancers. I mean, breast, nobody gets treated for breast cancer anymore with monotherapy or even doublet therapy for that matter. And so we're figuring out that treatment intensification clearly is a leader. Patients have longer survival times. They have radiographic progression-free survival times that far exceed patients that are just on single therapies alone. The problem is actually that getting that message to people has been slow. And when you look at the data, even among well-seasoned oncologists, I just saw some data on this just recently, that 30 to 40% of the time they're still giving monotherapy alone for metastatic prostate cancer, which is hard to believe given the data that we have now. So, so yes, it's here to stay. It's still, ADT is still the foundation. You know, all the studies required up until just recently, all the studies required ADT to be coexisting with these advanced therapies. And so, if you go away from that, then you're going to be off label. So, you know, I pretty much stick to label and do what I know is best, and I maintain ADT in all these patients, include it as the foundation with these additional therapies.
Yeah, I think it's been a slow process. I think it is not a good practice of medicine to use monotherapy except in rare occasions. Let's talk about David. Now we're getting into some things that are a little bit different. Let's talk about this EMBARK data and trial and what your thoughts are about that. What predict and so forth.
Well, important, I think, to think about what EMBARK is. It's men from an era before we had PSMA PET and had conventional imaging, but it had local therapy and then had PSA recurrence and quickly rising PSA. And now historically, most of the guidelines have said hold ADT and don't use it due to side effects of therapy until you have defined METs. This will change that sort of mantra, because we all know that if you have a quickly rising PSA after definitive therapy, you are going to have METs if we only wait long enough. And it's really an imaging limitation. So with the EMBARK data coming out suggesting that if you are going to start somebody on ADT, you're probably better off intensifying that therapy. And I think that kind of mirrors what the guidelines were, which is wait for METs and then use ADT. And we've always, for metastatic cancer, really been talking about the doublets and triplets like you just mentioned. So now we have data saying, hey, you have PSA recurrence, but no defined METs by imaging. that you, if you're going to start ADT, would want to consider adding an AR agent with it. And I think from my standpoint, two things that were fascinating was this idea of intensifying therapy and then de-escalating therapy later if you have a good response. So they basically would give them intense therapy and then back off of it, and allow people a holiday to try to recover. So that is a little bit of a challenge to this idea of low testosterone is going to give the best survival for forever. And then second, besides the de-escalation, is the idea of monotherapy AR agents. So really strong AR inhibitors, enzalutamide in this trial, the potential for monotherapy to potentially be better than even just an ADT agent alone. And so that, as Scott alluded to, now we finally have a label that includes an AR monotherapy agent. Those are the two things from that trial that I think will percolate into clinical practice. But as you just heard, our uptake of standard of care, things that are simple answers like doublet therapy for metastatic disease, have taken a long time to advance. So I think that monotherapy, enzalutamide, and de-escalation will have the same hurdles of getting taken up by the masses out in community.
Well, that was a great summary, and unfortunately, I think what you're saying may be true. We're rather slow to adapt a lot of things here, but yeah, looking back at we've made a lot of progress here with ADT, and then the take-home message is, what do you want to do with ADT? You want to deprive the tumor of testosterone. The lower you go, the better. So all these agents do, you want to use a good foundation, right? That works and keeps it down. And I think that now we got more intensive therapy and it works. And we got, that's when you really hit it with your best shot, I guess. The last thing I guess I want to talk about is that I mentioned changing the name to androgen directed therapy, David, rather than ADT. To sort of go along with all the changes that are occurring. Do you agree with that, or would you like something else?
Yeah, no, I'd love it. I mean, we keep the same acronym, and it really is because androgen receptor inhibitors, androgen biosynthesis inhibitors, androgen deprivation therapy with these agonists and antagonists, and coming soon is going to be androgen receptor degraders, and we're going to have androgen receptor inhibitors, fourth generation, that act on a different part of the molecule than what we're currently targeting. So it's the idea that it's not just deprivation, it really is directed at the androgen axis. And I agree that we're moving in a direction where we're going to have things that are not just about lowering the testosterone. They're going to be actually attacking the androgen receptor. And I think that that's important to recognize. And it's just a different way of thinking. I think it gets people having a conversation.
We came up with that term in one of our meetings, and I floated that on grand rounds to get some sort of a vote on what people thought. And interestingly, the urologists liked it, but the medical oncologists didn't. But we'll see. So, guys, thanks. I think that we've reinforced about the foundation of what ADT is, and I don't know how anybody can disagree with less than 20 and probably way less than 10. We talked about that. I think we've got enough data about it. It's not good, and it's the foundation. And we had some discussion about double and triplet therapy here as a new standard of care. Scott, out in the community, are people using doublet and triplet therapy, or is that finally turning around?
Well, certainly in my community they are. I think that again, where you have larger groups that have more sophisticated clinics and people that are really super specialized in this area, they're well versed in the data. This is happening on a regular basis. You're going to find pockets, though, where there's going to be, smaller groups that just may not have access to these resources and additional information, and you're going to see a lot more monotherapy in those places. And our role as key opinion leaders is to get out and help these people understand this data and make sure that they understand this is best patient care, really.
Wonderful. David, we're signing off now. Any final comments from you?
I'll just along those same lines, I think it's important to realize this is not a urology, medical oncology issue between the two specialties. It literally is driven by access to care, specialized care, if you're talking rural versus urban. And so really we're trying to push multidisciplinary access out into rural communities, and things like telemedicine should really help us drive some of that benefit and get uptake of what is considered standard of care now. But we need to do a better job of ADT, and that's urologists and medical oncologists both.
Right. Well, gentlemen, thank you very much for sharing your expertise with our audience. I always learn a lot, and we'll look forward to our next webinar, maybe on cardiac side effects and things like that. But until then, wish everybody a happy New Year.